Hello, good afternoon, everybody. This is Dr. Ashwin Kulkarni. I am a faculty in Department of Medicine in MS Ramaya Medical College, Bangalore. Uh, Hello. My topic of today's article is on importance of follow-up in the diagnosis of an overlap myositis. This is a review article. So, introduction. Overlap myositis is an idiopathic inflammatory myopathy characterized by myositis with at least one clinical and or an autoantibody overlap feature with a connective tissue disorder. The diagnosis requires high index of suspicion. Clinical features may be very subtle at the presentation, wherein continuous follow-up helps of overlap myositis. Here we present three cases of overlap myositis which we could diagnose during the follow-up. So basic tissue diseases like SLE, systemic sclerosis, who at presentation did not have any evidence of musculoskeletal involvement or muscle weakness, but during the diagnose these diseases. So hence we would like to tell that importance of follow-up in the diagnosis of these myositis. So first case, a 14-year-old male patient presented with history of thickening and tightening of skin around his fingers, hand, upper limb, chest and face since 1 year. He also gave difficulty of swallowing or difficulty in swallowing and regurgitation. So these symptoms are suggestive of systemic sclerosis. On examination, routine investigations were found to be normal. His anti-nuclear antibodies were positive in 2+, which were nucleolar pattern, and anti-centromere antibodies and anti-topoisomerase. A skin biopsy was done, which showed the thickening of dermis, homogeneals, vascular and periadenic cell lymphoplasmacytic cells. So these findings were features of systemic sclerosis. So based on 2015 scoring system by American College of Rheumatology, this patient had a score of above 9. That is, he had systemic sclerosis. After 3 months of this illness, he started developing weakness of the neck muscles and difficulty in holding his head upright, and also weakness of all four limbs. These were not there at the presentation. Because of the weakness, his creatine kinase was done, which was 1500 units per liter, which is very high. And because of the muscle weakness, the sternomastoid muscle biopsy was done, which showed periphyseal atrophy and diffuse infiltration of muscle fibers with perivascular infiltrates, which is a feature of dermatomyositis. An electromyogram was done, which was suggestive of myopathic pattern. In second case, we have a 49-year-old female patient who presented to the hospital with chief complaints of fever since 2 months and diffuse thickening and redness of her skin. Her ANA-IF was strongly positive, which was speckled pattern, and ANA profile was positive for anti-SCL body and PMSCL antibodies. This was strongly suspicious of systemic lupus erythematosus. After 1 month of this illness, she developed muscle pain and weakness of all four limbs as manifested by difficulty in combing her hairs, carrying foot to mouth, climbing stairs, and later progressed to involve distal muscles. That time her creatine phosphokinase, that is the indicator of muscle injury, was very high, which was 7973, and anti-Jo antibodies were positive, which is a feature of polymyositis. Her electromyogram was done, which was showing myopathic pattern of weakness. Muscle biopsy showed areas of necrosis, regeneration, and inflammatory cells infiltrated by CD4 lymphocytes, which is a strong feature of polymyositis. In this case, muscle weakness was not present at the time of presentation, but later developed and was diagnosed during the follow-up. In third case, we have a 40-year-old female who presented to the hospital with complaints of fever since 1 month. She had malar rash, diffuse alopecia, and multiple cervical lymphadenopathy. A lymph node biopsy was done, which was showing features of Kikuchi's disease, and her anti-nuclear antibodies were strongly positive, and dsDNA was positive. She was diagnosed to have SLE based on American College of Rheumatology criteria. 1 month later of the diagnosis of SLE, she developed myalgias and weakness of all the four limbs. On examination, she had symmetrical proximal muscle weakness. Her CPK levels were very high in the range of 2500, and electromyogram showed weakness pattern, myopathic weakness, which was feature of inflammatory myopathy. A diagnosis of inflammatory myopathy was made based on Bohans and Peters criteria and overlap myositis because she had associated SLE. A discussion. Overlap myositis is an inflammatory myositis with clinical overlap with other connective tissue disease and an overlapping antibody. Muscle weakness may be a late presentation. Regular follow-up helps us to identify muscle involvement. Detailed musculoskeletal and neurological examination should be done with serum creatine phosphokinase levels and electromyogram and overlap antibody testing and nasal biopsy whenever the scenario is necessary. Hereby, we would like to conclude that regular follow-up with specific clinical and lab testing is necessary for the diagnosis of overlap myositis. I would like to say that we see a lot of connective tissue disorders, but most of the time, muscle weakness may not be there at the time of presentation. So we conclude that specifically symptoms and signs related to muscle weakness should be seen at follow. And whenever muscle weakness is suspected, we have to do clinical lab workup like serum CPK levels, EMG, and muscle biopsy may be done for the early diagnosis and management of this overlap myositis. Thank you.